Can we invite Dr. Sadiq to talk on anastomotic leak after pancreatic donor?
Hi, good afternoon. Thank you, Baiju, for holding this in difficult circumstances, but I think we have a good audience. I think 50% is out for lunch, which is fair also. I'm going to speak about pancreatic uh, anastomosis leak following PD. And I'm not going to speak about what it does, but how to prevent that, because that's our main goal. It still remains the Achilles heel. So this works. Yeah. So this is the benchmark which you can see from Verona, 3,000 pancreatic odontectomies, saying 20% significant morbidity, 22% pancreatic fistula rate, and 2% mortality. And of the grade C ones, you can see that there is a very high mortality of 15 to almost 30% in these. And that's because when you have grade C pancreatic fistula, there are other associated complications related to organ space infections, sepsis, pulmonary, renal, etc., which contribute to the high mortality in C. So the question is that what do we do? So my first thing is we need to be able to identify which are high-risk fistulas. And we have these good fistula risk scores. Most often we use the alternative fistula risk score. And you'll note that all of them have certain important features, which is texture, duct diameter, and BMI. The problem with this is that you identify these high risk only on the operating table because these are parameters which have been assessed on the operating table. There are several groups which have worked on radiological parameters, and we did a small study, looked at how the PD diameter and the AP arterioportal enhancement suggests or reflects or correlates with intraoperative texture and diameter, and it correlated very well. And when we substitute this in the alternate fistula risk score, it correlated very well with the occurrence of fistula and clinically relevant postoperative fistula. So basically, I think it's important to identify these patients so that you can counsel them beforehand. You can get the best hand to do the anastomosis, adopt mitigation strategies. And of course, it helps in comparing studies because you generally don't know what is the fistula risk score when you are comparing outcomes of pancreatic fistula rates. This is one of the very valuable papers I've come across in recent times, which talks about prevention, mitigation, and management of postoperative pancreatic fistula by 60 expert pancreatic surgeons from 22 countries. And they discussed all aspects of this. What I want to bring to the notice is they looked at practice of 4 expert surgeons who had a fistula rate of less than 5% and what mitigation strategies they adopted. So what is creditable to note is it's a PJ by most of them, no drain, no somatostatin analogs, and no stents except one. Another interesting thing which came out in this discussion was that 80% of these expert surgeons went through a series of pancreatic anastomosis, finally coming to their after 3 anastomosis. And they all graduated from Duncan to duct to mucosa and from Cattle Warren to Brumgard. It just resonates with what I've gone through over this period. We assess the fistula risk. Now we do a modified Blumgard, no stents. I use high-risk patients octreotide, and we put a drain. But you know, still the rate of fistula is still high. And why is it? And as Ramesh said, I think there is some contribution with the surgeon in this, but it's difficult to document. This study, which looked at 64 surgeons with a fistula rate of 33.7 over a period of time with increasing number of pancreatic odontectomies and greater experience, were able to bring down their fistula rate. And they all adopted a PJ and omitted octreotide. So this is some food for thought that experience does count. And this is the kind of anastomosis which most people do, pancreaticojejunostomy, duct to mucosa, a meticulous suturing using the pair wash suturing technique. Most of them for small ducts would use loops, monofilament sutures. I'm sure all of the uh, great pancreatic surgeons sitting there adopt this precise suture placement, knots not too tight. And if there is a difficult stump, then even in that paper, people recommend that you get onto a dunking anastomosis as a last resort. So some of the myths we have debunked is type of anastomosis is not important. Stent doesn't mitigate post-operative fistula, and somatostatin analogs are not the Ramband that we have. What can we do now to mitigate this? And there are some exciting things on the table. One is this smart pan. Basically, it is a degradable starch microspheres which are coated with a bromomethyl blue, which is a pH indicator which turns color when there is an alkaline juice. And you can then sort of target the closure of the area where you see a color change. And hopefully that will help you, like in many other places, to detect leak and take care of it on the operating table. Single clinical study is available and we need to look further in this. Another alternative is degradable pancreatic stents. This study which has been shown, not very happy results, but something to think about and see whether this makes an impact on decreasing the fistula rate. This is another very interesting study which looked or analyzed whether total pancreatectomy would be useful. And they utilized an entropy balance analysis wherein you do a simulation of high-risk patients by giving weightage to the parameters which are uh, which can affect the outcome of these patients. So there were 202 high-risk pancreatic duodenectomies. They simulated this to say if we do a total pancreatectomy in these, what would happen? And naturally, there were no pancreatic fistula, but they also saw that the morbidity was low, although the major morbidity was not any different, but minor morbidity was less. Mortality was less in total pancreatectomy group. The interesting part is that in high-risk patients, when you look at these forest plots, the high-risk patients had a better outcome following the total pancreatectomy. So in high-risk pancreas and high-risk patients, this may be an option, and this is a food for thought based on these analyses. Can you do something in the post-operative period? Now, we know the drill. If there is a fistula, what to do, nutrition, antibiotics, drain management, and if there are complications, deal with that in a stepwise manner. Now, this one study looked, it's a meta-analysis of continuous drain irrigation in the post-operative period, seeing whether it mitigates the incidence of post-operative pancreatic fistula. Of course, these are about 9 studies. They had different protocols, different solutions were used, different rate of irrigations were used, and they usually employed it on post-op day 0 or 1 and stopped it when the amylase levels were near normal. And interestingly, it showed, the forest plot showed that all POPF and clinically relevant POPF were decreased in the group which had continuous drainage. So there were 782 patients, 9 articles, and they all favored the use of basically continuous irrigation in the post-operative period. Again, something I'm not sure whether anybody has tried this and what is their experience, but something which is there in literature to look at. So in conclusion, post-operative pancreatic fistula is still a serious morbidity despite the good surgeries which we can do. And even in those hands, there is significant morbidity and mortality. I think the first step in mitigation is to predict so that you know who's at high risk. Then you put your best hand or expert person to do, or as Shailesh and Ramesh say, that you standardize those things in such a manner that it is done in the same way throughout and gain the experience. And you need to still look for, because over the last 4 decades, we have not made much impact on decreasing this, although the mortality has decreased. And these are some exciting things on the horizon, which may have an impact on mitigating the dreadful complication of post-operative pancreatic fistula. Thank you very much.
Sadiq is slightly unclear. You said no drain, but the data showed drain.
No,
Use
I
of drain.
said drain.
Drain and
I
no
said
stent.
Drain. All of them use drain.
So octreotide agreed doesn't reduce the fistula rate, but just, there is animal data and some, unpublished clinical data from some centers that given intra-op, not, pre-op and all that, it does harden the thing just a tad so that sutures become a little. So if you find that it's slipping through and you're not a very experienced surgeon, I'm just wondering whether, it might help you just to harden that temporarily. It just becomes gland becomes just a little firmer.
So, even in that, because I thought that paper is really classic, which I mentioned. And in that, almost 40% of surgeons, expert surgeons, use octreotide in high-risk glands. So there is a role in high-risk gland, but unfortunately, it is not well documented as far as the data is
So
concerned.
we have a trial from Prakash Center, if I remember, which is showed the high risk only didn't have a difference. Is Prakash
It didn't
there?
have any
Yeah,
difference.
it didn't have a difference.
It didn't high risk. So,
Hi, Dr. Sadiq. Can I ask a question?
hi, Nilesh.
So recently, a couple of years ago, there was a big publication from the Dutch Pancreatic Cancer Group, about 900 patients. Their leak rate was also around 29 or 30%, quite a high leak rate. So in their group of patients, all prospective data, not randomized, they have put early PTBD in grade B and C fistula. If they diagnose a fistula, there is immediate PTBD. And the group of patients where the PTBD was done, there is a dramatic reduction in mortality. So even the high risk group of patients. So my question to you is that I know it's maybe very old fashioned, but would a T-tube to divert the bile help? Because in this large group of patients, 800 patients, that seems to have helped bile diversion. So when you do a high risk anastomosis, do you think an additional bile diversion at the time of doing a pancreatic or duodenectomy may help? I mean, I know people have done Machado loop and separate loops, and that doesn't seem to have worked. But with this recent data, I don't know what's your opinion on that.
So, I mean, Nilesh, when we started doing PDs at SGPGI, used to put number of tubes. Shrikant would remember, we would divert the bile, we would divert the loop and all that. And it didn't make any difference. This interesting data which you are suggesting, unfortunately, I have not read that. But again, it's like, although the high risk fistula business is relevant, identifying them, but not all high risk will leak and not all low risk will not leak. So I don't know wherein you would put, but regarding the point that intraoperative diversion when there is a high risk is something which is open to discussion, and I would think case by case that whether it is relevant or not.
I think what he means is the biliary sepsis worsens, so it's not intraop. It's as early as possible.
Yes,
the moment you detect it
paper
after
says-
surgery.
the
No,
paper
but he's
suggests,
suggesting, can we do it intraoperative?
What I'm suggesting is that this paper did it only in about 20% of patients when they got a fistula. 80% didn't have bile
Because
diversion.
biliary sepsis does make the patient much worse. There's no doubt about that. So I think that point is, valid.
No, the other
Whether
reason I'm
you
saying
can
is
change
that
it by doing
because
it or not.
in B and C fistulas, in India, it is much more difficult to manage patients because, of resource, difficulties, and it's very difficult to manage patients once they're into a situation where they get PPH and, bad sepsis. So, and this seems to be, I'll forward you this paper. It's a very good paper. And the Dutch Pancreatic Cancer Group is very, very careful. All these surgeons are who have operated these patients, 7 centers from all over Netherlands, have all done more than 300 Whipples each, so they are not, they're all very experienced centers.
So Netherlands people are very fond of antegrade drainage for everything, including biliary strictures.
No, this was not antegrade. This was done after the pancreatic leak was diagnosed.
Okay.
This was a PTBD done in around 120 patients.
So I think what I'm trying to kind of bridge between what you're trying to say is that, yes, I think you need to tailor treatment in the event that you are dealing with a fistula where you feel it is the bile diversion, which is complicating a bad POPF B and C, then an individualized PTBD to divert the bile is fine. But again, one point that which we have actually put in place for more than 10, 12 years now, around 2011 or 12, that the amount of limb that I keep between the PJ and the hep J is definitely helping us in the sense that when I get a POPF now, I rarely ever, perhaps a case in a year, where if it's a POPF C, that I also see bile in the drain when the bile duct anastomosis is intact. So that would mean that the bile is kind of mixing with the PJ leak. But with the long limb, I've rarely ever seen bile with the pancreatic fistula. So that can be something which can be done in drop. It's not a mitigation, but it's a preventive.
So
The way to look at it is you get the jejunal limb more than telling you the centimeters. The apex of the jejunal limb should be between the PJ and the hep J. Without tension on the PJ, without tension on the hep J, and yet the apex, the blood supply for the limb of the jejunum should be in between. So from your side, this is the PJ and this is the hep J. The arch of the blood vessel should be such that it is like this.
so
Exactly, exactly.
Shailesh, what you're saying is like, when we were doing dunking, we were seeing bile more often when there is a leak.
Yeah.
When you're doing duct to mucosa, since the rent in the jejunum is very small, generally we are not seeing bile. So
Generally.
that would be one of the things.
One
So
of the
it
things.
depends what kind of anastomosis you do.
Also, but
Yes.
regardless of the variation in anastomosis that we may adopt on table or for whatever reasons we may have, I think having a little bit of jejunum
Yeah,
in
yeah.
between is
Absolutely.
not harmful. The other advantage that I've seen is that even with all these measures, if you are unable to control your fistula, your easiest way is to do a disconnection early with surgery.
Th-
And then you have the easy limb available to safeguard the hep J and then do a virsangostomy to get the pancreas out.
That makes perfect sense because to deal with the fistula surgically, if you have a long limb, it's
You
advantageous.
just get a
You can
stapler
just-
there. You can put
absolutely.
your finger there at the caudate near the
Absolutely.
stomach and lift up that limb without
Put a
touching
stapler.
the mess around and then put a stapler there.
Absolutely.
But the irrigation papers seem counterintuitive because half the I think the actual leaks are quite high. The radiological leaks are quite high, and some of them are probably prevented by adhesions. So whether the irrigation would actually, break those adhesions, I don't know.
So that's why I think it's not mainstream.
Even wrapping up the momentum, I found it only delays the leak. It doesn't prevent every single one where I've used it. If it's delayed,
I think wrapping up is not usually for preventing leak, but to cover the vessel so that if there is a leak, you would have a protective cover. So that's what I believe. Yes.
Sir, just to add to the point what Dr. Shailesh sir was telling, uh, many times no, when we want to leave little more length of the jejunum between PJ and HJ, it becomes more, sometimes we worry more that that may kink on itself and may sometimes block the passage of PJ. And
so GP pump we used to actually separate it into a rule loop also for
So-
the tough ones.
So the key is that, it has to be a lazy kind of a thing. It's not an acute thing, one. And two, if you're worried about the torsion, that worry comes when you have a very thin and a very small bile duct. If you have a dilated bile duct with an obstructive jaundice patient, that's not going to do a torsion. But if you have a very small bile duct, then I agree that that limb in between can have a torsion. I've
it may
experienced it
become
once.
hindrance to the drainage.
But then for that, the trick is that in any event, you fix it to the gastrohepatic omentum which you have divided, so that you have the V of the divided gastrohepatic omentum and 2-3 interrupted sutures on the serosa of the ascending limb and another couple of them on the descending limb as it comes to the hep J. And then you are reasonably sure it's not. I've seen it only once.
And you
That
don't
would-
need a lot of space for pancreatic
Yeah.
juice to go.
Yeah, yeah.
So
Sir, one more thing, sir.
Baiju, do you want us to wrap the session or because it's an
Sir.
interesting one?
Many times, sir,
Just a
one,
comment.
Sir, can I make a quick comment? So knowingly or unknowingly, the distance between PJ and HJ, what we were doing is, we physically measure the distance between the pancreatic stump and the bile duct stump 2.5 times. That is what we take it from the PJ to HJ to allow peristalsis. I don't know how it helps. Something like that. We were unknowingly doing it. Right now, we know that it is better.
Okay, I think
Thank
we'll
you.
close the session now.